So I reached out and I actually thought I'm going to bless you with a few jokes to begin with because laughter is important. And these are all 8-year-old approved for my grandson. So, did you hear about the Italian chef who died? He passed away. What do you call a Roman with a cold? Julius Sneezer. Where do pepperonis go on vacation? The Leaning Tower of Pisa. And my finale. What do you call a fake noodle? An impasta. So there you go. A little laughter for Jay. So thank you. All right, great. Thank you for having me. This was great. Okay, let's see. All right. Well, I am excited to be here and going to talk to you a little bit about kind of a passion project that I've been working on with the organization that I work with, AstraZeneca. And very honored to present this, although you're going to get just a little peek under the hood. So you're not going to see everything we're kind of doing, but we're doing some amazing things. So I wanted to talk with you about a few things that I thought were relevant to this particular session. And one of them has to do with how we are trying to identify areas that are what we would call deemed opportunity with high unmet need to set up infrastructure for early detection. Oh, here we go. There we go. I can see myself there. And I have no official financial disclosures other than I am employed by AstraZeneca. However, in this space, I've been in the early detection space for about 16 years. Started out doing this in research with Claudia and David many years ago with Wellstar Health System in Atlanta, and have worked with many of you in this audience over the years. So very proud to be where I am today with AstraZeneca and just continuing this important work. So my role at AstraZeneca is to lead an initiative called the Lung Ambition Alliance for the US. And the Lung Ambition Alliance is basically a global collaboration between AstraZeneca, the Global Lung Cancer Coalition, and Guardant Health, with an overarching, real, true ambition to eliminate lung cancer as a cause of death. And the hope is together through working and as well as bringing on other organizations that we can work toward a higher goal of achieving doubling the 5-year survival rate globally for lung cancer. And there are over 53 countries that actually have someone representing each particular country through this work. And there's kind of a list there. And I know that Italy has someone here as well. So, but what I'm here today to talk with you about is the US and some of the strategies that we are looking to deploy through the US Lung Ambition. And just kind of a little snippet. We primarily have nailed it down to 4 primary strategies that we are supporting through the work of the US Lung Ambition that I'm leading in this role. And my main goal is to really to accelerate early diagnosis to create a stage shift across the US. And one is establishing or creating program infrastructure. And what I mean by that is the reality is we're never going to find lung cancer early unless you have the mechanism or processes in place to do that, whether that is through an incidental pulmonary nodule program and or lung cancer screening program. And I'd love to see us get to the place where we really redefine screening, in that we tend to say lung cancer screening and we define it as people meet these criteria, therefore they go in and they have an exam and let's see if you have lung cancer. And I'd love to see us change that to really focusing on true early detection, which is comprised of both that model of lung cancer screening, that traditional screening method, but also incidental pulmonary nodule programs, because that too is a way to screen for lung cancer early. And studies tend to show, and organizations that are doing this, we are finding that you're finding a lot more lung cancer when you do both together. So primary focus, increase the screening program infrastructure. Next is increasing screening uptake. That is, how do we drive people to screening? Now we've got the program in place. How do we get patients actually screened? So we'll talk a little bit more about that. Build coalitions and partnerships, because we can't get there alone. It takes us all of our expertise working together to solve for this problem. There is not a one answer solution. And then my fourth priority here is to improve quality of care and delivery of innovative medicine. So how do we do that, right? So we've got these strategies, and those are my 4 strategies that I shared with you. And one of our objectives through creating our program infrastructure strategy is to establish early detection programs throughout the US. We have not rolled this out yet. It's forthcoming. We're still working internally. I've only been in this role for a few months, but it's our hope and our vision is that we're going to do something meaningful and help support communities of high unmet need and help to set up some program infrastructure in communities where it is currently lacking. And our goal of that is going to be obviously to increase screening uptake, improve stage shift, help look and evaluate processes that improve screening adherence, evaluate efficient workflow practices. And one of the things that we're looking to work on in collaboration with like the National Lung Cancer Roundtable is refining a true implementation, like a playbook or something. And we'll be able to potentially use this pilot, this community demonstration pilot, to maybe even validate the effectiveness of it. Another strategy that we have that I mentioned earlier is to increase screening uptake. So we have a goal to drive or be able to say, hey, we help hand deliver 1,000 people for screening. And how do we do that? Again, adopt this go big mindset. And one example of something that we're getting ready to pilot, we've not ever done this before, and I have no idea how it will go, but hopefully, fingers crossed, it'll go well, but it'll be really good insight. So we are sponsoring a NASCAR race in the US. And we have partnered or teamed up with a local community healthcare organization that is going to be on site talking with the participants or the attendees there that meet screening eligibility. And they're going to have a protocol or a pathway in place to be able to sign these attendees up for screening. Don't know how well received it will be, but we're going to test it. And we're going to try it. We're going to be there for all 3 days, the whole entire weekend. And we know not everyone is native to this particular community. Many are coming from all over, but we're going to have a protocol and a pathway in place as well to have these meaningful conversations, capture their information, and be able to follow up to see if they indeed went through and went on with screening. So the questions become, now again, that's just a peek under the hood of all the really cool things we want to do. But when it comes to how do we do those things? How do we help create the screening infrastructure? How do we increase screening uptake? We're a large organization. This is a huge problem to solve. The 2 things that kept coming to my mind was, where do we start? And then how do we prioritize for maximum impact? So coming from an industry organization, we're constantly approached with some really amazing ideas and project suggestions. But the reality is, as all of us are employed by someone, we all have limited funds and resources, and each one of you is a valuable resource within your own organization. So you can't do everything. We're not able to really boil the ocean. So let's find a starting place. So what I did is I said, I really need to better understand what is the current state of screening across the US. So when in doubt, what do? You hire people who are much smarter than you. And that's what I did. I reached out to people a lot smarter than me and said, listen, I need a map of the US. I want you to put out all the healthcare and hospitals across the country. Then superimpose which ones are Commission on Cancer accredited, which ones are NCI designated, which ones are comprehensive cancer centers, which ones are accredited for the go-to foundation centers of excellence or designated, and then which ones participate in the ACR registry. And then this interesting pattern started to emerge. Then I said, let's superimpose the mortality and incidence rate of lung cancer on top of this. And it became very clear rather quickly, we have some problems. And I didn't want to just do it by rates. I wanted to do it by population count. So what you see here, this is what you would call in the US if you were to say, let me just pull up a lung cancer incident rate map. Now, I'm no expert when it comes to this type of data, but this is what you would see. So you look at this and think, oh, wow, this is where all the incidents of lung cancer are occurring. But it's actually based on, I've learned, kind of a theoretical model of this is the probability of where this is going to occur. It's not based on actual numbers. And this is our mortality rate map in the US, where, again, based on probabilities and all these mathematical formulas of where people are actually dying from lung cancer. So again, going back, where do I start? I thought I need to find out, I want to see where the bodies actually are. And so what we did, based on the initial map, how it was emerging, we came up with these 4 key attributes. And this was working collaboratively with folks outside of AstraZeneca and those really, really smart within AstraZeneca. And through all this conversation, we settled on these 4 main attributes. And this is where this is very novel. This is something specific to us. There is no perfect formula for any of this. But what we looked at first was incidence count, the actual where the bodies are across the US. And these, basically think of these as the ingredients of our cake. So we looked at incidence count, and we gave that a really high importance because where the highest number of people getting lung cancer, to me, is like, okay, let's start zooming in. Then we looked at something called screening positivity rate, which I understand and have learned is kind of comes from the whole COVID thing. And basically that is where you take the total number of patients or people diagnosed with lung cancer, and then you look at the actual number of tests in that community being performed, and you kind of look at the spread. And the wider the spread, the bigger indication that there is a need for screening. So we kind of applied that concept here and gave it a medium importance or relevance. Oh, sorry about that. Then we looked at mortality per incident count, and this reflects these communities where people are being diagnosed with lung cancer in large numbers, real bodies, at much later stages and are dying of lung cancer. And then we looked at kind of the health equity issue, the high risk factors. We factored in age, tobacco, poverty, insurance type things, and then gave that a rating. So when we mixed all of that into our cake, we got a very interesting map. But before I show you that map, I'm going to go through each of these so you can kind of see what those maps look like. So this, when we actually look at where the bodies are, where people in the US are actually being diagnosed in higher numbers of lung cancer, these in blue represents the communities where there's just this higher density of lung cancer. And then when we looked at screening positivity rate, the communities that are in maroon represent the communities where lung cancer, the numbers of lung cancers being diagnosed compared to the actual tests that are being performed. And granted, there's no perfect way to do this. And yes, we use claims data for this. The maroon indicates the communities where there could potentially be more screening occurring. Okay. All right. And then our mortality per incident count, the darker the red here, the maroon colors, indicate the communities throughout the US where people are being diagnosed with lung cancer, theoretically, I guess, at a later stage and are actually dying from it in higher numbers. So these are counties where the death number from lung cancer is higher compared to others. And then our last ingredient in the cake, which is our high risk factors. So this is where we kind of factored in and kind of combined, and there's some science behind this, the tobacco rates, the age, the insurance, the poverty. And so the darker, the purple, tend to be the communities where this is occurring in higher numbers. So now this represents our cake. So this is, I call it the $1 million photo, but it really didn't cost $1 million. But this is what we were after. And again, this is not perfect, but it helps to give us a baseline. Like, where do we start? And the communities that you see that are the darkest green are in the top 100 counties of the US when we factored in all of those 4 attributes and then just kind of what bubbled up to the top. And this is not something that we are exclusively going, hey, these are the only communities in the country we're supporting. The idea behind this is, if we have so much in resources, and I've got 2 projects that I'm looking at, and we're trying, again, to help establish program infrastructure, help increase screening uptake. This helps me kind of guide, what do we support? Where do we go? And I believe that is kind of it. So that's it. I should have probably ended with a final joke, but if you want more, feel free to give me an email and I'll be happy to answer any questions. I appreciate your time and attention. Thank you.